Hi, I'm Dr. Abhishek here. I'm MD Medicine and I completed my DM Neurology from NIMHANS last year. And currently I'm a postdoctoral fellow in epilepsy at Amrita Institute, Kochi. So today we'll be discussing status epilepticus. We'll have a bird's eye view of its management and the therapeutic aspect of it. So what shall we cover over here? We'll start with introduction and then we go to the history and examination points of it, followed by the importance of EEG and neuroimaging. We'll see what we will have a look at what the EEG features are of status epilepticus, when do we suspect and when do we order it, and followed by that the therapeutic and diagnostic aspects of the same. After that, we will see why we are doing what we are doing, that is the epileptic brain model, and followed by that the take-home messages. We'll start with the definition of status epilepticus. Now, everyone knows, everyone has a vague idea of status epilepticus. If somebody just asks you out of the blue and they ask you what is status, so you will say that it is a prolonged seizure, correct? It is a prolonged seizure, but that is not enough to call to like explain what status epilepticus is. For that, we need to have a bit more nuanced discussion. So we'll go to the very basics. Not everyone has seizures. That is, a normal person does not have status epilepticus. Not even every seizure, a patient with epilepsy has status epilepticus, not every one of them. So there are some intrinsic mechanisms in the brain that are responsible for the termination of the seizure and ongoing seizure activity. They usually work most of the time. So what happens in such in a patient with status epilepticus? These mechanisms fail to terminate the seizure. These mechanisms fail to terminate the seizure, or they don't get initiated at all. So either they don't get initiated at all, they don't come into effect, or they are ineffective. So they are not, they fail to terminate the seizure, which leads to both these mechanisms. They'll lead to an abnormally prolonged seizure. A prolonged seizure can be it can be a different time. It can be different time for different people. But when do we call it an abnormally prolonged seizure? When do we call it abnormally prolonged seizure? So at this time, we have Eugene Trinka, who gave us this wonderful definition of time when it comes to status epilepticus. In that, there is time T1. What does time T1 mean? Time T1 is the point after which you will term it as an abnormally prolonged seizure. That is time T1. We will come to the importance of it in the next slide. But for now, you people just understand that it is an abnormally prolonged seizure if it crosses this time T1. Okay. Next will be, because of this status epilepticus, there will be long-term consequences, and that is why we are worried about it, right? So for after status epilepticus, there will be long-term consequences. They do not happen in every patient of status epilepticus if that status is terminated before a particular time. They happen after this time T2. So what does this long-term consequence, what does this long-term consequences mean? It means there can be neuronal death. it can be an injury, or it can be an alteration of the neuronal networks, which will lead to epilepsy over a period of time. And this time T1 and T2, they are different depending upon the type of the seizure that we are dealing with. So just let us recapitulate. What is status epilepticus? It is failure of initiation of these mechanisms or failure of these mechanisms which are responsible for termination of the seizure. It leads to an abnormally prolonged seizure, that is time T1, after which it leads, we will call it an abnormally prolonged seizure. So that is a definition. But not every status epilepticus goes into a long-term consequences. It can have long-term consequences, but only after time T2. What is long-term consequences? It can be death, it can be neuronal death, it can be neural injury, or it can be alteration of the brain networks, which will lead to epilepsy. And because of this, we have different time T1 and T2 for different types of seizures. So let us look at it another way. What is time T1? It is the time beyond which the seizures do not stop spontaneously. Do not stop spontaneously. Means it is likely that they are not going to stop on its own. So by this time, the treatment has to be initiated. By this time, treatment has to be initiated. And what is time T2? T2 is beyond which there is a self-perpetuating neuronal damage. And this is the time by which it should be latest controlled. It should be latest controlled. So T1 is initiation of your treatment. And T2 is you should control the seizures by this point of time. Otherwise, it will entail long-term consequences. Now, the next part, I told you, right, that this time T1 and T2, it is different depending upon the type of the status we are dealing with. If we are dealing with a bilateral tonic-clonic seizure, bilateral tonic-clonic status epilepticus, time T1 is 5 minutes, T2 is 30 minutes. If we are dealing with a focal status with or without impairment of sensorium, the time T1 is double, that is 10 minutes, and T2 is also double, that is 60 minutes. So we do have some gap when it comes to a focal status epilepticus, but that gap reduces by half when it comes to a generalized tonic-clonic seizure, which is anyway more likely to be presented to casualty in your emergency department. Focal status epilepticus, when they come with impairment of sensorium, they also present to the casualty, but then the technicality of the diagnosis, the processes by which your diagnosis starts will be delayed in a patient with altered sensorium, because we'll be thinking about in those lines rather than these lines. You will eventually come to it, but then the time T2 shall be crossed by that time. So here we will, this is the time, this time T2, that is the time beyond which, before which we should start the treatment. This is the overview of the therapeutics of convulsive status, as we can see over here. This is stage 1, that is pre-monitory status epilepticus or an impending status epilepticus. That means the patient has just come to casualty with an ongoing seizure-like activity. If it is motor phenomenon, the time is 5 minutes, and if it is non-motor phenomenon, the time will be 10 minutes. So we have some laxity over here in non-motor, but that laxity is only for 5 minutes. The patient has just been for 5 minutes, correct? That means less than 5 minutes. So we don't know whether we are dealing with a status epilepticus or not. So we term this stage as a premonitory stage or an impending status epilepticus. We really don't know. At this point of time, you give benzodiazepine. That is within 5 to 10 minutes of the patient presenting to the casualty. And after benzodiazepine, if the status activity continues, we call it established status epilepticus. Now, you don't wait. You again, once it is refractory to benzodiazepine, we give an anti-seizure medication. That is again within 10 to 30 minutes of the onset, total status epilepticus duration. If the patient is not responding to this anti-seizure medication, which we give over here, we call it refractory status epilepticus. When do we call it refractory status epilepticus? RSE. When the status is refractory to one benzodiazepine and at least one anti-seizure medication. That is when you start straight away with a third line drug, that is IV anesthetic agent. We will come to that, what all these third line drugs are. But for time being, your onset to diagnosis or onset to IV anesthetic time should not be more than 30 minutes in motor seizure and not more than 60 minutes in a non-motor seizure. That is what. Now, the purview of this current lecture ends at stage 3, because the next step, super refractory status epilepticus, is a whole new it has a lot of developments, and there are so much of advancements daily in the therapeutics of it, and the guidelines of which are murky still. So we will just talk about it very briefly, and we will be concentrating on stage 1, 2, and 3 management predominantly in our current. You cannot treat if you don't know what we are dealing with. So we start with classification of status epilepticus. We finished with definition. Now we go on to classification. Primarily, the status has to be classified by the presence or absence of motor phenomena. So if a status has motor phenomenon, we call it status epilepticus with prominent motor phenomena. If it does not, then without prominent motor phenomena. The first group over here is very easy to diagnose. They present with a tonic-clonic convulsive status epilepticus. They can present with myoclonic status epilepticus. They can present with focal motor status epilepticus, or it can be a tonic or a hyperkinetic status epilepticus. All in all, they have a predominant motor phenomenon. So they are easy to diagnose. Your threshold to diagnose seizure will be very less when such a patient presents to you. What happens here in the next one? That is when we do not have a prominent motor phenomenon. This is very difficult to diagnose. I mean, very difficult to suspect. It is easy to diagnose, but it is very difficult to suspect. So in this comes non-convulsive status epilepticus, which is the most commonly missed cause of a reversible cause of unexplained unresponsiveness everywhere in ICU as well as in the emergency department. It also can that also can be generalized. It can be focal. It can be just an aphasic seizure. It can also be just a visual hallucinatory seizure. It can be a gustatory seizure. It can be olfactory seizure. But what will distinguish this subgroup is that all will be stereotyped. Stereotype means if it is a hallucinatory seizure, visual hallucinatory seizure, they will suppose a person is coming to my OPD with with a complaint of recurrent visions where he sees his friend, he's repeatedly coming from the right hemifield and then coming to him, talking, and then going away repeatedly. So it is a same kind of visual hallucination which keeps coming and going, So if it is stereotyped, you should suspect an epileptic activity going on if a patient comes with such symptoms. The patient with such symptoms will not have a label on their head that I am status epilepticus. They primarily come with such complaints, and it is your job to as a physician, it is your job to diagnose such cases as a focal status epilepticus, because it is very reversible and you can actually prevent a lot of comorbidities which would have had affected the patient if not for your treatment. Just to recapitulate, so refractory status epilepticus is status which persists despite two appropriately selected drugs, out of which at least one is benzodiazepine. Okay. We do not have a time factor over here because that has already been established by the definition of status epilepticus. Next step is, what is super-refractory status epilepticus? A refractory status epilepticus, when we start them with IV anesthetic agents, still, even for 24 hours, you have given this at least for 24 hours, and still the patient is seizing. That means the patient is either refractory to this anesthesia for 24 hours, or they recur after withdrawal of these anesthetic agents and requires anesthetic reintroduction, correct? So this is refractory status, super refractory status epilepticus. And the anesthesia can be midazolam, phenobarbital, propofol, thiopental ketamine, and they should be at anesthetic doses. Now, where to suspect status? Where to suspect? You should suspect it out of hospital setting, in OP, as well as in IP. Out of hospital, they usually come to the emergency department to begin with. Here, the onset is often not clear, and they are just found seizing somewhere, or they are just unconscious if it is a non-convulsive status epilepticus. If they are just found unconscious, chances are the time T2 has already been crossed. In OP, they present with typical hallucinations, like the one I just told. Like it can be visual, it can be olfactory, it can be auditory, it can be gustatory. They come with hallucination, or they can come with ictal paresis, just like a focal motor seizure. Focal motor seizure is a positive seizure. We have ictal paretic seizure, which is a negative seizure. Means they present as weakness, they present like stroke-like symptoms, but it is a negative motor seizure which occurs in due to activation of supplementary motor area. And then they can present just as tremor, that is epilepsia partialis continua. You will not diagnose it if you did not suspect the epilepsia partialis continua in such a patient of a tremor which has come to OPD, who is conscious. And in IP, they are found typically in ICU in an unresponsive patient of unexplained origin. The only question at that point you need to ask is the patient in status? Once you ask this question, the entire machinery will come into force to diagnose it. These are the common causes of status epilepticus, meaning to say that status is not a diagnosis on its own merit. It is not a diagnosis on its own merit. It has a cause. Just like you should not stop at diagnosing a cough. You need to go into the depths of it, that the cause is because of so and so illness. Similarly, why has the status epilepticus presented to you? It can be idiopathic, it can be remote symptomatic, it can be traumatic, it can be drug overdose, it can be low anti-seizure medication, it can be infection, it can be a stroke, like it can be ischemic stroke, it can be hemorrhagic stroke, etc. And the mortality is typically high in the stroke and the hypoxia anoxic seizures. So what do you do in casualty? You look for subtle clinical features like just minor jerk, just discernible minor jerks, or it can be an epileptic nystagmus. Epileptic nystagmus has a fast component opposite to the side of the lesion. It can just be a spontaneous dilatation constriction that is known as hippus. Just a simple pupillary examination can diagnose seizure by, you can diagnose the seizure just by simple pupillary examination. Then comes a googly over here, that is gaze deviation. So when we localize an MCA territory infarct in the brain, this is the MCA territory infarct. So the MCA territory has frontal eye field. Frontal eye field, the normal function is it pushes the eye towards the opposite side. So the right frontal eye field will push the eye towards the left side, and the left frontal eye field will push the eye towards the opposite side. This is the normal function of the frontal eye field. So what happens in stroke? In stroke, this frontal eye field is damaged. So the eyes will be ipsilateral. Ipsilateral. So the an easy way to learn this is, to memorize this is, the eyes point towards the lesion in stroke. They literally indicate you that this side is a MCA infarct, like that, a patient. Now you are daily seeing this patient who has who is unresponsive. You know that, okay, and he has eyes towards the lesion, that is ipsilateral. Suddenly one day you see them that the gaze deviation is away from the lesion. That means this lesion has started becoming overactive. This overactive lesion pushes the eye towards the opposite side. So the eye deviation is contralateral. Suddenly it was ipsilateral, and then suddenly it is now contralateral. At that point, you should start suspecting a seizure. Or obviously subtle asymmetry in tone or power. A tonic seizure will increase the tone subtly on the opposite side, and a negative motor seizure will reduce the power on the opposite side, and vice versa. A status epilepticus, you really don't know the onset if the patient is coming to ED. So the question when did it start does not make that much of a sense to the witness or the bystander who has brought the patient to your department. So the prudent question at this point of time is to ask last seen normal, just like in stroke. That will give you an approximate time of onset, and that will give you approximate total duration of status at this point of time. If you have a witness, that is well and good. You can know the evolution of the semiology of the seizure, so that you can get an anatomical correlate of it in casualty. If you do not have that much of time to we usually don't in casualty. When we find such a patient, we better note down the witness account details, so that once the patient is stabilized, you can go back to the witness and then call them up and then ask them what happened actually, how it started. It can give you an etiological history also. Most important aspect which has been which is being frequently overlooked in casualty setup is drug history, not of the patient but of the family members and the friends. Suppose a person comes with unresponsiveness, just unresponsiveness. It is highly rewarding if you just ask them the drug history of family members or the people who, or the roommates, like people staying with the patient. uh, it can be a suicidal ingestion of a phenobarbital of the roommate who is a patient of epilepsy. It can be just that. And you will not diagnose that phenobarbital, everything will come normal. Everything will return normal. You will not diagnose the phenobarbital toxicity if you do not order that specific investigation. So it is highly rewarding. Just a simple question. What is a drug? Like what if other family members are having any illnesses of the people who are staying with the patient, and the drug history of the same. Not every abnormal movement presenting to casualty is a status epilepticus. It can be a psychogenic non-epileptic event also. It is a great mimicker, literally speaking. That means they may present with abnormal movements. They can present with jerks. They will look like seizures. They can look like, and they might look like seizures. And because of that, because of the pressure of time, they might end up receiving benzodiazepine. If you are giving them a higher dose, like repeatedly, still the jerking is not finished, not getting over. You will give them you might give them the high dose, and they will go into a comatose state. And then they might end up in ICU as an unexplained unresponsiveness. Okay, this is just the diametrically opposite aspect of it. So we really need to know how to differentiate the speed of onset of seizure. That is when the witness account, if at all, comes into play. Absence of tongue biting, the state of eyelids during the event. A person with psychogenic non-epileptic seizure will apply force in direct proportion to your effort in closing the eyelids. Okay, so this is a very important, just a simple measure by which you can really make a difference over here. Duration of convulsion, speed of postictal reorientation. Typically, it takes half an hour to 1 hour to maybe 2 hours also for postictal confusion to settle down. But the patients with a psychogenic non-epileptic events, unless they are a physician or a neurologist, they will not know the speed of postictal reorientation. So they might just as well come up back in a time which is disproportionate to their severity. And an absence of a postictal stertoral breathing. All these points point towards a non-epileptic event. It will help you. So we have covered the historical aspect of it, the the examination aspect of it. Next, we go on to the treatment aspect. Okay, sorry, the diagnostic aspect. The most powerful tool in your armamentarium is your clinical examination. Nothing beats clinical examination. It is very easy to observe. So how this is clinically, the clinical improvement is what you are looking for in all the patients of status epilepticus. And that is a fact of life for all of us in the emergency department. But what happens when the patient fails to improve clinically? When the patient does not improve clinically. So it can be either of the two things. It can be just a post-ictal state, or it can be a non-convulsive status epilepticus. So EEG is must in all the patients who are not responding clinically after a seizure has subsided. So when to ask for EEG and when to start when to start when to escalate your anti-seizure medication based on this EEG. That is explained by this newest concept, that is electroparaclinical gap. I'll explain that to you. So the electroparaclinical gap is the gap between the EEG findings and your paraclinical finding. Okay, paraclinical in the sense the clinical, laboratory, and imaging data. Clinical and paraclinical. So if your EEG findings they exceed your paraclinical findings, that means there is a electroparaclinical gap. I'll just make it more clear by two examples subsequently. Say, for example, you have a patient of an acute renal failure and you do an EEG. It has typical serotyped EEG pattern, which you expect in a case of the acute renal failure. At this point of time, there is no electroparaclinical gap. It is absent. That means there is no additional seizure burden that can be helped by addition of additional anti-seizure medication or by escalation of the same. So when you do not find any electroparaclinical gap, you don't be aggressive. But if you have a patient of non-convulsive status epilepticus, where EEG changes clearly exceed what can be expected from your imaging, laboratory and toxicology finding, that means there is a significant electroparaclinical gap which can be helped by a consequent anti-seizure therapy. So you should be aggressive in starting and escalating the medication. So what to look for in EEG? We have Salzburg criteria for EEG. First of all, you look for epileptiform discharges, that is more than 25 in 10 seconds. That means more than 2.5 hertz. That is the epileptiform discharges. If it is that, you can diagnose that as electrographic seizure. Now, if you do not have this more than 25, you have less than 25, for example, in 10 seconds. So what do you look for? You look for evolution of the seizure. You look for evolution. You can look for evolution in 3 aspects. That is frequency, morphology, and location of the seizure, of the electrographic seizure. What is frequency evolution? That means previously it was this, and then the frequency reduces over a period of time. This is the frequency. What is morphology? Morphology means the shape changes like this. So this is clearly evolution. Or they can change, they can evolve in location. So previously it was over the frontal region, then it is spreading to parietal region, and then occipital region. So there is an evolution in the location. So frequency, morphology, and location. If there is evolution, then also you can diagnose it as a status epilepticus, electrographic status epilepticus. Now, if you have a video that is corresponding to the EEG, you can find time-locked, changes, time-locked movements in the video, which are corresponding to the pattern of any duration that will establish an electroclinical seizure. If you do not have the video, but you are seeing the patient clinically, and if you give an anti-seizure medication with which there is both EEG and clinical improvement, still you can diagnose it as electroclinical seizure, electroclinical status epilepticus. If it does not fulfill all these criteria, still you have a seizure which is less than 2.5 hertz or more than 1 hertz, or it is less than 1 hertz but more than 0.5 hertz, that is way less than your 2.5 hertz. Still, if you have fluctuation or a modifying response to your anti-seizure medication, still you can diagnose it as a possible status epilepticus, or the alternate name is interictal continuum. Okay. So this is the same about the non-conscious status epilepticus when it is applied to that. Now, it is very much clear if it is an electrographic seizure or it is an electroclinical seizure. But what does it mean when we call it as a possible status or just an interictal continuum? That means you should not be satisfied by this diagnosis. You should suspect, but you should not be satisfied with the diagnosis. And you should really look for other causes of unresponsiveness and other causes, and you should go into the other causes of status epilepticus. If this is that, then how do we correlate it? By imaging. So at this point of time, you better go with an ictal MRI to confirm status epilepticus. Okay. What to look for in ictal MRI, we will come to that next. Once you have diagnosed as status, what to do next? Ask for a continuous EEG monitoring to quantify the burden. What advantage will you have by doing this? You can prognosticate the patient based on their temporal and spatial evolution, and that will in turn help in the kind of therapeutic management. Suppose you are seeing a patient who has had right parietal seizure, focus seizure, and next day you are seeing on the left. That means you should you should ask for a repeat imaging to confirm if they have developed a new lesion on the contralateral side, because your EEG has picked up. What to look for in an MRI, ictal MRI? So we look for two things over here. We look for cerebral hyperperfusion, focal hyperperfusion in the cerebrum. That can be done by arterial spin labeling or by contrast. So it reflects the increased metabolic demand of a brain tissue. It can give you direct anatomical correlate. So first anatomical correlate was by semiology, who witness has informed you or you have yourself seen the seizure. Next is by the EEG data. Third is neuroimaging. So by three modalities, you are able to find and you are able to correlate anatomically. Next is the cytotoxic edema that can be diagnosed by T2 or flare hyperintensity. What does it indicate? It cytotoxic, that means neuronal damage. It gives you that the time T2 has been crossed now, but still you should not stop. So what to do now that you have a status epilepticus on your hand? You cannot just go into the very detailed analysis of each byte of information that has come to you. Okay, you have to act fast. That is 0 to 5 minutes of the patient entering or from the onset, whichever is earlier. 0 to 5 minutes. You give benzodiazepine. You give lorazepam. IV lorazepam is preferred. That is at 0.1 milligram per kg. That means if a patient is 40 kg, you give 4 milligram. If a patient is 30 kg, you give 3 milligram. If a patient is of 20 kg, you give 2 milligram. Whatever the kg, you reduce one decimal point to the left, and you give that much of milligram of this, up to 4 milligram. You don't go beyond 4 milligram in the first attempt. If they are not responding to 4 milligram within 5 minutes, you give another 4 milligram. That is till 8 milligram. You can go up to 8 milligram. That is, if the patient is 70 kg, you give 4 milligram. And then after 5 minutes, you give 3 milligram just to reach the maximum dose permitted by the weight. If you do not have IV access, do not waste time in getting it. You give intramuscular midazolam. Intramuscular midazolam. Typical dose is 10 milligram. In children weight less than 40 kg, the dose will be half of that, that is 5 milligram. And this should go simultaneously with your routine emergency management. You should obtain large bore IV access on both the sides. This is the most commonly neglected aspect of status epilepticus in casualty. We don't order beta HCG level in urine that often, and we do not look for urine drug screen that routinely. So this has to be a routine practice in all the status epilepticus patients. Check blood glucose. If low, you give D5 or D25, and then a brief neurological examination, as I told earlier. Next 5 to 30 minutes. Next 5 to 30 minutes. If the patient is not responding to your primary benzodiazepine, you straight away go for high loading dose of one of the following anti-seizure medication. All are equally effective in managing a status. Typically, we prefer to give, usually we prefer to give levetiracetam in our casualty. So the loading dose is 60 milligram per kg. We routine, people in routine practice, they usually give 1 gram or like 1.5 gram, but the permissible dose is 60 milligram per kg, maximum till 4.5 kg. So if you find a person who is 50 kg, you better load him with 3 gram at a step. Okay, maximum you can go till 4.5 gram. Similarly, by fosphenytoin or phenytoin, valproate, lacosamide, phenobarbital, these are the preferred agents for terminating the seizure. At this time, you should not waste in just calculating the doses. You just give it. You just see that it is not more than 4.5 gram. Anything less than that, you just give it. Okay, and you reassess ABC. You order an EEG. By this time, it should be ready within 30 minutes. You order a head CT. If you are suspecting stroke, you go for CT angiogram. At this point of time, you should have an adequate information that if adjunctive medications are indicated, that is antibiotics and antiviral medications, if at all required. If D5 is given, give thiamine irrespective. And once EEG is started, once the status is confirmed, order a continuous EEG monitoring for the reasons I explained previously. Next is if it is a focal seizure, you go for the second anti-seizure medication. If it is a generalized seizure or it is unresponsive seizure, you go straight away with IV anesthetic agent in form of propofol or midazolam or ketamine. My personal favorite is midazolam and ketamine. Continuous EEG. Why should we do it? Because it has 95% specificity for diagnosing seizures at 72 hours. You should not stop at that. You should ask for anti-seizure medication levels by this point of time, because you do not know whether the patient is a fast metabolizer of one of the medications or not. So you have given a loading dose of phenytoin, but what if he is a fast metabolizer? The levels might have not reached at this point of time. So you better advise an anti-seizure medication levels for all the drugs which have been going on, so that you know that you are above the therapeutic level. And ICU transfer has to be done. Central venous access has to be done. And before 1 hour, LPCSF has to be finished. In that routine, above routine, you should ask for gram stain culture, HSV PCR. And it is, if it is available, you straight away order for a viral encephalitis panel, autoimmune panel, and paraneoplastic panel. Meaning to say that you should keep a very low threshold for sending this in a case of status epilepticus. And you will not suspect it. You will not suspect it, or you will not diagnose it if you are not ordering the EEG in the first place. Why do we go for such an aggressive investigation in such a short duration of time? Because of this. Time is brain. Time is brain in the sense, if there is a sub part of refractory status epilepticus that is known as new onset refractory status epilepticus. The patient is presenting to you without any pre-existing neurological comorbidities and without an active epilepsy, and you do not have a structural, metabolic, or a toxic cause to explain it. So at that point of time, we diagnose it as NORSE. Why is it important? Because 50% of it are autoimmune in origin. And if it is autoimmune origin, we have treatment options available for the same. As simple as that. And there is a subcomponent of NORSE. This is more important for you for MCQ purposes. It is known as FIRES. It is a subcategory of NORSE. And there is a febrile illness between 2 weeks and 24 hours before the onset. And age is not a bound over here. So typically when we say that it is a febrile infection following which status started, we typically assume that it will be about children. No, age is not a bound over here. This can come as an MCQ. Why is it important? The epileptic brain model. This model explains that the longer the time the epileptic brain activity is ongoing, the longer is the higher will be, the more are the chances that there will be a structural brain damage. If you catch the patient in early non-comatose status, non-convulsive status epilepticus, the chances of improving is good. If you catch them here, when the patient is already having a coma with a generalized periodic discharges, the chances of them improving will be poor. So what happens over here? We have two triangles. One is brown triangle, another is the green triangle over here, as we can see. The brown triangle indicates the structural damage, or metabolic derangement. So this indicates the primary reason why the status epilepticus is happening. And this green triangle indicates functional reserve. That is that much of redundancy in the brain that is able to take up all the insults coming from that damage. But it can only work so much. The more the seizure persists, the less the burden increases, the less the functional reserve becomes. Now, what happens over here? The more the status epilepticus persists, the total burden of status epilepticus will rise, and that pushes the patient from low morbidity to high morbidity towards mortality. We have to prevent that. How do we prevent that? By giving an aggressive and early and aggressive treatment. So it will increase the functional reserve. This is the primary goal of the treatment, to increase the functional reserve. And if you do that, the structural damage will automatically come down. But the story does not end there only. There is another aspect to the treatment of it. That is the burden of the treatment. That means the treatment which you are giving, suppose say propofol, it itself leads to hypotension, which will finally add on to this burden of the status epilepticus, and finally it will lead to the impact of burden. So it has to be a very balanced approach between low threshold and high threshold, and a combination of multiple treatment strategies which will lead to an optimum outcome of the patient. This is just the explanation of it. Everything gets translated into the impact of burden, as I told over here. So just to wrap up the things, we have gone through the history, definition, classification of status epilepticus, the history, the examination of it, the electroclinical diagnosis, that is the EEG, then anatomical diagnosis, that is by neuroimaging. We have gone through the therapeutic aspects and diagnostic aspects of status epilepticus, and what will happen if you do not treat that, and the end result of it, that is the structural brain damage, which is poor prognosis. And finally, we concluded with the epileptic brain model. So the take-home points, will think from the first principles, that is, your treatment cannot be better than your diagnosis. You will not treat it if you have not diagnosed it, correct? And your diagnosis cannot be better than your hypothesis, plural. So if you have not considered it altogether, you are not going to diagnose it. And if you are not going to diagnose it, you are not going to treat it. Simple. So you will not diagnose it if you are not suspecting it. One simple change in perspective can amplify so much over a period of time. So you need to keep a high index of suspicion in unexplained, unresponsive patients, both in ED and ICU. OP phenomenon will be very rare, but you need to keep your eyes open for that also. But in ED and ICU, it is a fact of life. What to do when you have an unexplained, unresponsive patient? Just order this stat EEG. Remaining, everything will take care on its own. So strike fast by EEG, strike hard once diagnosed by anti-seizure medication, because time is brain. This concept is very important. It is on everyone's tip of the tongue when it comes to stroke. Everyone says time is brain, time is brain. But when it comes to status epilepticus, non-convulsive status epilepticus, to be more specific, this goes for a toss. So the same concept you have to keep in mind while treating an unexplained, unresponsive patient in ED, which is very common. This is how I conclude by references. These are my references. I have taken significant number of figures from all these references. I have written that also, and from the Continuum latest edition 2022, which was published recently. Thank you. We can start the discussion.
Thank you, Dr. Abhishek. I will say it's a different perspective of status what we had. So if anyone has doubt, can message or post it here, or can ask directly, or later on they can message to me, or you can contact to Abhishek also on the same mail what he has written. Fine, I think then we should conclude. If any messages comes, I'll convey to you, Dr. Abhishek.
They can ask on the group also, as well as they can me over here.
Sure.
Okay. Thank you.
Okay.